Good afternoon, everyone. I'm surprised it's a desert session, and I hope you won't fall asleep. So these are my disclosure, and as Bertrand said, all what I will present to you is based on the CISR guidelines, and the CISR guidelines are for oncogeriatrics, and are fully endorsed by the EAU guidelines, which must be named nowadays as EAU-CISR guidelines. So we are facing a trouble, and we are facing a real epidemic. Senior adults will become the vast majority of people in the quite near future. If you see this slide, it's expected that in 2050, more than roughly a fourth of the entire population in America, in Europe, in China, in Asia, will be over 60 years of age. So definitely we are facing a trouble. You know that for low Gleason score, that is up to Gleason 7, the specific death rate is minimal. I just show you this old cohort published 2009, patient untreated with a localized disease, and you know the curves very well. Most of the deaths come from non-prostate cancer. So clearly dealing with senior adults with Gleason up to 7, we have to probably to think twice. Totally different for high-risk prostate cancer. Even in senior adults, you see it on the bottom of the slide, even if you are above 74 or 75 years of age, roughly 50% of the deaths at 13 years are mainly because of prostate cancer. So definitely, high-risk disease kills senior adults, no question. And what happens in real life? That was true in the previous slide in the US. That's also true in Europe. Low-risk disease, no impact on survival. Intermediate risk, a marginal impact. High risk, a significant impact. Regionally advanced or metastatic disease, a very significant impact. So the disease itself plays a role, no question. What happens in real life? In Ireland, there was a very interesting and provocative survey. Local treatment for T1, T2 disease stratified by Gleason score. On the left, you see the local treatment when the Gleason is below 8. Above 70 years of age, 50% of the men are treated locally, whatever the treatment is applied. That's acceptable. Let's say it might be acceptable. But on the right of the slide, you see the data for Gleason above 7, that is 8 to 10. And again, you see, although the disease kills 50% of patients at 8 years, you see that above 70 years of age, roughly 50% are treated locally, 50% never received any form of local treatment. So clearly, senior adults are undertreated. Clearly. I showed you survival at 8 years or 10 years. Okay, you might say, 70 years of age, life expectancy is roughly 76, 77, doesn't matter. Totally wrong. You already showed this slide this morning. Remember, the reference is 2016, but the population included there was analyzed from 2001. And every year, we had some extra months of survival. What is clearly shown here, if you have 80 years of age, 25% top percentile, that is people without any comorbidities, they have an expected life expectancy of 11 years. 80 years of age, if you're in good health condition, in 2001 you had roughly an 11 years life survival. On the opposite, if you belong to the lowest 25th percentile, your individual life expectancy is close to 4 years. All these figures improved, and nowadays if we conduct the same survey, probably it will be even more if you belong to the top 25 percentile. So they are undertreated and they live long. So we are facing a problem. Comorbidity is probably the key factor to analyze. And you know that the health status per se is a driving factor of survival. Age probably is a very weak factor to consider. Health status also is a question of patient possibility to receive any form of treatment. So health status is absolutely mandatory to analyze, and you have to analyze at least 3 different parts. And I will show you how to do it in practice. It's feasible. You need less than 5 minutes for a patient, not more, but on top of that, you need to have a dedicated geriatrician. And that's probably where the problem is. If you want to analyze the individual life expectancy of a patient and all the comorbidity of the patient, I guess most of you are urologists, radiotherapists, or medical oncologists, you won't have enough time to spend half an hour or 2 hours to check all the comorbidities of patients. So probably you need to refer a patient to a specialist, a geriatrician. The problem is there are not enough geriatricians worldwide, and we need to screen who needs to be referred to a geriatrician who doesn't need. And probably the best available tool that is available, that is fully published, that has been shown to be the best one, is a very simple one, is a G8 tool. You have all the criteria there. They are not fantastic. We are far from very high-level science. It's just, is a patient able to eat? Is the patient has some weight loss? Is the patient takes take pills? What about body mass index, etc., etc.? If you use this tool, you get to a score. And very simply speaking, if your average tool using the G8 is above 14, the patient belongs to the 25 upper group of patients, that is, patients who do not require any form of geriatric assessment. If it's below 14, he must receive a geriatric assessment. And that's clearly the best screening tool, but it's just a screening tool. Based on this screening tool, the geriatrician will spend and use dedicated tools to analyze the comorbidity. The best one, probably this one, the cumulative illness score rating geriatrics. Again, you have a lot of things, and for each point, you rate from 0, absolutely no problem, to 4, extremely severe impairment for each point. And based on this, you can stratify, they can stratify patients at least in 3 groups. Perfectly healthy, they never see them, so it's relevant. Vulnerable patients, and that's probably the key factor there. They have some grade 2 problems on the previous scale, on 1 reversible grade 3. These patients are considered vulnerable. If you act actively on them, you might reverse this illness and put the patient again as if they were perfectly healthy. On the opposite, they might be frail. Frail means they have several grade 3 or 1 grade 4 irreversible comorbidity. If they are frail, probably you must think twice or even better 3 times before doing anything. The key driver of survival is not the disease, it's all the comorbidities. But this takes time, so it probably is not for us to use it. But that's not enough. A patient is alive, so he has to do with other things. The first one is the activities of daily living. Clothing, eating, walking, etc., etc. It's very simple. In senior adults, one impairment of this activity of daily living is significant. They also have instrumental activity daily living. It's managing money, being able to give a call. It suggests that you have your brain, you have your movement, you have muscle, etc., etc. To check that, probably the best tool to use is the minicog, probably we never heard about the minicog. We never heard about all that. But that's what the geriatricians are doing. So it's of interest to know what they are doing. You must be aware that usually the geriatricians are able to reverse one or two activity of daily living provided they are clear. Usually it's impossible to reverse instrumental activity daily living. And probably this is the most important slide of my talk. You are facing a senior adult, starts with a G8. It's above 14, and the G8 is really less than 5 minutes. It can be given by a nurse, no problem with this. It's above 14, treat the guy as if he was 60. If it's less than 14, then you refer the guy to a geriatrician, and the geriatrician will check the comorbidity and the activity daily living impairments. Two categories then, reversible, clear action for the geriatrician to reverse that, and you treat the guy as if he was fit. This group of patients represent what we call the vulnerable patients. You have more side effects, you have more comorbidities, you have more impairment of activity daily living. Probably the disease per se, provided it is asymptomatic, is not the key driver of survival. And definitely you have to think in a totally different way. Okay, you decided to go for surgery because the patient is fit. Is surgery realistic in senior adults? Well, this is a large cohort published by Briganti. It's a multi-center cohort, a huge number of patients. You see on the top right, patients above 70 years of age. Upper line, they have no comorbidities. Charlson score index is equal to 0. Bottom line, Charlson comorbidity index is higher than 0. Clearly, you see two things. The specific death rate is absolutely constant, whatever the age, but the other cause of death increase with comorbidity, which is not a surprise. That's a clear signal that, again, if you consider surgery, that's fine, but if you're treating patients older than 70 years of age, really taking into account the comorbidities is a major point. Remember, Charlson comorbidity index is not an everyday tool to be used. You decided to go for surgery, you must be aware that the postoperative complications are mainly related not to age, but to comorbidity. Whatever the comorbidity you consider, they are mainly related to comorbidities and not to age. This is a large cohort. I could show you several cohorts. They all go in the same direction. Again, comorbidity is a key driver. In details, you must also know that when you're dealing with senior adults, there are less potency after surgery, which is not a surprise. There are more incontinence after surgery compared to younger men. So if you consider surgery, it's not a crazy thing. I'm not saying it's the best thing. I'm just saying it's not a crazy thing, provided you clearly say that it's at risk of increased incontinence and impotence, provided the guy is potent before surgery. Radiotherapy, I have very few data. I have only one slide of it, not because it's not useful. If you read the EU guidelines, you will see we consider surgery and radiotherapy exactly at the same level. But you must add ADT for high-risk disease, 2 or 3 years, maybe 16 months might be enough, but it's not yet fully endorsed by the guidelines. And in intermediate risk, at least 4 to 6 months. Again, have a look about the cardiovascular history. So there's no question radiotherapy is a very good treatment in senior adults. Surgery is a very good treatment in senior adults, provided they need to receive this kind of treatment. And what about ADT monotherapy, which is very often used? We have randomized controlled trial clearly showing that ADT monotherapy is inferior to ADT combined with radiotherapy. The two randomized controlled trials on the left on the slide. And we have a SEER database clearly showing exactly the same thing for patients T2, T3 above 67 years of age, or T1C up to 85 years of age. Locally advanced disease treated with ADT monotherapy are clearly undertreated. And we have a randomized trial comparing immediate ADT versus watch and wait. And we are facing a trouble with this trial. It was said this morning that we have a clear evidence that is better. I partly disagree with this. The overall survival is better, but there is absolutely no specific survival difference, suggesting the ADT lowers the non-specific mortality, which is quite surprising. We should have expected the other way. Second, very important message, 30% of patients never received any form of ADT because they just simply died before any side effects. And probably the only patient that benefit from ADT monotherapy, they are M0, are the patients at the highest risk of dying between 3 and 5 years after randomization, which is patients with a PSA above 50 and a PSA doubling time less than 12 months. Remember, it's post-hoc analysis, so it's not that clear. And we have a retrospective SEER database showing, again, exactly the same thing. ADT monotherapy versus nothing. The benefit is very weak. You don't see any difference between the dotted line and the continuous line. You don't see any difference because they absolutely overlap, whatever the trial you consider specific survival or overall survival. So this is my last slide. Treatment is not based on age. Treatment decision must be based on the risk of dying from the cancer, that's a cancer natural history, of the risk of dying from other causes, mainly related to comorbidities. Treatment have side effects that might be a little bit different in younger patients than in senior adults. And all the complications of these side effects might absolutely interfere with the quality of life of the patients. And finally, as usual, discuss with the patient. It finally is a patient's decision to choose what he will receive. Thank you.